Radiation Safety in the Computed Tomography Environment, presented by Astarita Associates, consultants in medical physics and radiation safety. Some general information to get started. Radiation is often depicted as a mysterious, deadly force. In truth, there is nothing mysterious at all and has been studied for over 100 years since its identification in 1895. Radiation detection, measurement, and control are extremely common events, and they happen on a daily basis in most medical installations and research facilities. The more the public understands, the less frightening it becomes. As we know, radiation can be a very beneficial diagnostic tool. The radiation quantities and units most often utilized for radiation measurement are the Coulomb per kilogram, or Roentgen, which is the measure of radiation exposure in air, the gray or rad, which is the amount of energy from any type of ionizing radiation deposited in any medium such as water, tissue, or air, and the sievert or rem, which is the biological effect of a rad. 1 gray is equal to 100 rads, and 1 sievert is equal to 100 rem. Entrance skin exposure is the measurement of radiation output at the point of skin entry for an X-ray examination. Peak skin dose is reported in gray or milligray. Effective dose is the measure of the potential harm from radiation and is reported in sieverts or millisieverts. Natural background radiation is the relatively constant low-level radiation from naturally occurring sources. These radiation sources can be the Earth, cosmic rays, and naturally occurring radionuclides found in the body. Background radiation levels vary. The levels may depend upon location, altitude, and the amount of natural radioactive material in the ground. The Andes Mountains of South America have the highest known natural background level of 1,000 millirem, or 1 rem per year. The Nuclear Regulatory Commission states that the average natural background in the U.S. is 310 millirem per year, or 3.1 millisieverts. Included in this slide are typical natural background levels. New York City is approximately 3 millisieverts per year, or 300 millirem. Denver is approximately 5 millisieverts per year, or 500 millirem. Grand Central Station is greater than 5 millisieverts per year, or 500 millirem. This is because of the granite walls. The Andes Mountains are approximately 10 millisieverts per year, or 1,000 millirem. As mentioned, the approximate natural background radiation, or the ubiquitous radiation dose in the United States, is 3.1 millisieverts, or 310 millirem per year. However, there are also man-made sources which account for an additional 3.1 millisieverts per year averaged over the population. The man-made component comes from medical procedures such as nuclear medicine, CAT scan, dental x-rays, radiology, as well as consumer products such as building materials, smoke detectors, tobacco, and even some ceramics. Including both the natural and man-made components, the total background in the United States is approximately 6.2 millisieverts per year, whereas 37% of that comes from radon and 36% is from medical procedures averaged over the populace. The yellow sections on the graph are the sources of natural background radiation. The blue sections represent man-made sources of radiation and their contributions to the total background level. There are no known proven carcinogenic effects from radiation levels in the order of magnitude comparable to background radiation. Typically, exposures received by the staff from diagnostic procedures fall well within background radiation levels. Medical procedures account for 36% of the total annual background radiation in the U.S. Although the radiation dose from these procedures are averaged over the population, each procedure may contribute more radiation to the individual patient. When relating radiation dose to the patient, comparing the dose with a known quantity such as natural background radiation is often helpful to relay fears and gain perspective. The term BERT stands for Background Equivalent Radiation Term and is now becoming more common in the literature when comparing radiation doses. A CT angiogram may result in a dose to the patient of 12 millisieverts. This is equivalent to 4 years of natural background radiation. In comparison, a chest X-ray is only 1/10 of a millisievert, or 10 millirem, which is equivalent to only 10 days of natural background radiation. To gain some additional perspective, a flight from LA to London could result in a dose of 0.05 millisieverts. Although variable, due to the complexity of the procedure, a cardiac catheterization can yield doses over 260 millisieverts. Radiation therapy procedures are much higher, but the radiation dose is fractionated over time and localized, not a one-time whole body irradiation event. Individuals working with radiation and radioactive materials are labeled occupational workers. The dose limits to occupational workers are higher than the general public because it is expected the worker will be exposed to a radiation dose as part of their employment. The limits are established well below the level where deterministic effects are seen, and the limits minimize the potential risk from stochastic effects. The annual whole body limit to an occupational worker is 0.05 sieverts, or 5 rem. The lens of the eye may receive 0.15 sieverts annually, and the extremities may receive a dose of up to 0.5 sieverts per year. The limit is higher for extremities due to the lack of sensitive organs. To ensure occupational workers are not exposed to excessive amounts of radiation, personal monitors are used to assess the radiation exposure and are exchanged on a routine basis. The personal monitors simply measure the amount of radiation to which the person was exposed. The monitor itself offers no protection against radiation exposure. Personal monitoring is required when an individual is likely to exceed more than 1/10 of the yearly occupational limit, which would be 500 millirem per year to the whole body. Monitoring is also required if an individual handles radioactive material or works in a high radiation area, such as a radiation therapy treatment area. Therefore, it is usually not necessary to monitor radiology secretaries, file clerks, and operating room personnel. Monitors are typically worn at the collar and positioned outside of the protective apron during fluoroscopy procedures. Pregnant workers are to wear the badge at waist level to monitor fetal exposure. Be sure to know your local regulations and consult with your medical physicist regarding monitor use. Computer tomography technologists are often not monitored because they are inside a shielded control booth during any radiation use. The room shielding assessed at acceptance test by a medical physicist mitigates the requirement for personal monitoring. If CT fluoroscopy is an option on the unit, personnel in the room for the fluoro procedures will need to wear protective garments and be monitored. There are 3 cardinal rules of radiation safety. They are time, distance, and shielding. A common term used in radiation safety is ALARA. This is an acronym for as low as reasonably achievable. With regards to radiation safety, our goal is to keep radiation exposure as low as reasonably achievable. It is through the ALARA principle that we strive to maintain exposure to radiation as low as possible. One such method is using time. Minimizing your time around the radiation source will reduce your overall exposure. It is important to work in a manner to safely complete the task at hand in the shortest amount of time. Because in CT, the staff will remain outside of the room for all radiation exposures, the time around the source of radiation is not so much a factor. If the facility is performing CT fluoroscopy exams, time inside the room should be limited during the exam to only what is actually needed. Another tool in the radiation safety arsenal is distance. Distance offers great protection from radiation. Radiation exposure follows the inverse square law. As you double your distance from a radiation source, your exposure is reduced by a factor of 4. Doubling your distance results in 1/4 of the radiation exposure. Whenever possible, think about moving back when you must be in the room with an active radiation source. The inverse square law, shown in the diagram, can calculate your reduction in exposure by moving away. Simply, if you double your distance, you quarter your exposure. If you triple your distance, you receive 1/9 of the exposure, and so on. Shielding of radiation should be utilized wherever appropriate. In CT, the walls of the scan room and entrance doors are usually shielded with lead and/or concrete. Standing outside of the scan room will offer protection from the radiation source and the scatter it produces when interacting with the patient. The shielding layout and the radiation protection survey are performed by a medical physicist to ensure the safety of the staff and the public. Radiation safety in CT will be the responsibility of the technologist and the staff working in the scan room. Remain outside of the shielded room during all CT scans. Be aware of all entrances and personnel who may have entered the scan room to care for the patient or retrieve an item. If the unit is capable of CT fluoro, protective equipment must be utilized in the scan room. Principles of time, distance, and shielding must be practiced at all times. To ensure patient radiation safety, always verify the patient and the exam to be performed. A routine review of the CT protocol should be performed by the radiologist, the medical physicist, and the technologist at regular intervals. New protocols should be reviewed by the medical physicist or the radiologist prior to scanning patients. Technologists need to be familiar with the CT unit and how each scanner parameter affects patient dose and image quality. Computed tomography technology has made significant advances in the past 15 years. Here are some examples of the different applications currently being utilized in CT. From the upper left, clockwise, first is a conventional diagnostic CT typically used in radiology, but can be used in any application. In the upper right is a portable CT used in emergency applications or intensive care units. On the bottom right, a special procedure CT application, and on the bottom left, a PET CT unit. However, the most important component is the production of X-rays in the X-ray tube. Through the process of thermionic emission, electrons are boiled off the cathode and directed towards the target, where interactions create Bremsstrahlung and characteristic X-rays. The tube may be energized for long intervals, therefore a great amount of heat is generated. The cooling system is extremely important to manage the heat units produced to ensure proper function of the unit. CT units typically have the following components: a rotating tube within the gantry which provides many X-ray projections through the patient, a collimated X-ray beam to prevent scatter from reaching detectors outside of the scan area, heavy filtration to eliminate low-energy photons and create as close to a monoenergetic beam as possible, X-ray detectors to collect photons and measure transmission and attenuation, a computer system for collecting data, processing, and reconstructing images, and monitors in order to review the resulting images. The X-ray beam rotates around the patient within the scanner gantry such that multiple X-ray projections pass through the patient. The X-rays produced, while paired with an electronic detector array, document the pattern of densities in the patient. Using this data, the CT will create an axial cross-sectional image from the mathematical reconstruction to be viewed by the technologist and radiologist. This diagram depicts basic CT operation by showing only two projections. Figure A displays a pattern in the subject. The attenuation of the subject from all the solid cells from vertical and horizontal projections are listed. If the beam passes through 5 solid cells, the value is 5. This is done for each row and column. Figure B assigns each cell a value by using the sum of the row and column for the location of that cell. Figure C displays the resulting matrix from all the cells. The bottom right figure assigns a shade of gray for each number, 10 being white, and each consecutive lower value a shade darker. The next two images are windowed to display the values we want to see. The last image in the bottom left windows all values at 7 or higher as white and all other values as black. The result is our original subject. Volume Computed Tomography Dose Index, or CTDI-VOL, is a standardized parameter used to measure scanner radiation output. CTDI-VOL is reported in units of milligray for either head exams, which use a 16 cm diameter acrylic phantom, or for body exams, which use a 32 cm diameter phantom for measurement purposes. For the same technique settings, the CTDI-VOL reported for the 16 cm phantom is about 2 times that of the 32 cm phantom. The reported CTDI-VOL by the scanner is based on measurements made by the manufacturer in a factory setting. Upon acceptance testing, annually, or upon replacement of a major component, a medical physicist will measure the CTDI-VOL to verify the correct output of the unit and to ensure protocols meet CTDI-VOL requirements. CTDI-VOL is not patient dose. However, it may be used to estimate the dose to the patient. The relationship between CTDI-VOL and patient dose depends upon many factors, including patient size and composition. The American Association of Physicists in Medicine, Report 204, introduces a parameter known as Size-Specific Dose Estimates, SSDE, to allow estimation of patient dose based upon CTDI and patient size. For the same CTDI-VOL, a smaller patient will tend to have a higher patient dose than a larger patient. In this example, 2 patients are scanned with the same technique and the unit displays the same CTDI-VOL for both patients. However, if patient dose was calculated for both, the dose of the smaller patient would be higher. This example includes a comparison of a smaller and a larger patient. Both patients receive the same size-specific dose estimate. However, the technique of the smaller patient is half the larger patient. CTDI-VOL provides information about the amount of radiation used to perform the study, which in turn could enable us to calculate patient dose. CTDI-VOL is a useful tool to track across patients and protocols for quality assurance purposes. It allows us to identify problem protocols that have a higher than required dose. CTDI-VOL can be used as a metric to compare protocols across different practices and scanners when related variables, such as image quality, are also taken into account. The ACR Dose Index Registry, or DIR, allows comparison across institutions of CTDI-VOL for similar exam types. The dose length product, or DLP, is calculated by the scanner. DLP is the product of the length of the irradiated scan volume and the average CTDI-VOL over that distance. It represents integrated dose in terms of total scan length. The unit for DLP is milligray centimeters. It's the CTDI-VOL in milligray multiplied by the length of the scan in centimeters. If the average CTDI-VOL is 20 milligray for a scan, and the scan is 15 cm in length, the resulting DLP is 20 milligray times 15 cm, or 300 milligray centimeters. Acquisition parameters define the technique that will be used in each protocol. They are set in the CT user interface. Changing a single acquisition parameter will affect the resulting CT image and dose to the patient. Operators of the unit should understand the effect when the following parameters are changed. X-ray technologists working on a CT scanner should be familiar with the following technical factors and how they affect the image and if there are any trade-offs with regards to dose. The parameters we will discuss are kVp, MA, mass, effective mass, time per rotation, scan mode, pitch and table feed, table increment, detector configuration, and the reconstructed slice thickness. kVp, or kilovoltage peak, is the peak potential applied to the X-ray tube, which will accelerate electrons from the cathode to the anode. Tube voltage, in turn, determines the quantity and quality of the photons generated. An increase in kVp will change the X-ray spectrum such that the maximum energy and average effective energy are higher. An increase in kVp will increase the amount of photons and the intensity of the beam. Increasing the kVp will increase the dose to the patient by a factor of the new kVp divided by the old kVp, quantity raised to the n power, where n is approximately 2. Exposure time per rotation is the amount of time set in order for the gantry to make one complete rotation. Longer rotation times will produce a higher exposure, however they could introduce motion of the patient. Increasing or decreasing the time per rotation will have a proportional relationship with dose to the patient. Doubling the time, for example, will double the dose to the patient. Tube current, or MA, determines the number of electrons accelerated across the tube to produce X-rays. Therefore, doubling the MA will double the amount of photons produced. If there are not enough photons for image formation, the image will appear noisy. Since noise is the limiting factor for what can be identified in a CT image, too much noise results in the image being less than optimal. MA is directly proportional to patient dose and will also double the amount of scatter originating in the room. Therefore, it is extremely important to balance the amount of noise and the patient dose by appropriately selecting the MA for a protocol. Mass is the product of tube current and the exposure time per rotation. Depending upon the scanner, changing the mass as a single parameter will affect the product of the time in MA by changing either one or both. It will affect the image and the patient dose the same as MA and time per rotation as discussed in the previous slides. The unit is milliampere seconds. Keeping all of the factors the same, patient dose is directly proportional to mass, same as it is for MA and exposure time per rotation. CT scanners offer a variety of scan modes which describe how the table moves during an exam. Scan modes used in CT include axial scanning. During an axial scan, the exposure will stop after each exposure to allow the table to move to the next position on the patient. Typically, the table movement is equal to or extremely close to the area being exposed to avoid overlap of the slices. It is a step and shoot method of scanning. Helical or spiral scanning maintains a continuous exposure of the patient while the table and the patient move through the gantry simultaneously. When first introduced, this was a major upgrade to the scanner's capabilities. In some units, gantry tilt may be limited with respect to helical exams. Dynamic scanning is only for specific applications which tend to involve some sort of body function. An example would be a perfusion study used for determining blood flow. In a dynamic scan mode, the table may not move while multiple acquisitions are acquired in one location. Examples of these studies include, as mentioned, perfusion studies, bolus tracking studies, or test bolus studies. It is extremely important to manage these protocols to ensure excessive dose is not administered to the patient in one location. Dynamic scans often have larger CTDI vol values because the scanner may report the sum of the CTDI values from each rotation. During these scans, it is important not to have the same diagnostic quality as imaging exams because the scans are utilized for identifying blood or contrast flow through a particular body location. Table feed is the movement of the table through the bore of the scanner over a full 360-degree rotation. It is defined as a rate for a helical scan and is usually in millimeters per rotation. Table increment is the same concept except it is the movement of the table in between axial scanning exposures. It is the movement of the table between each individual scan in the series. Axial scans will tend to have a table increment equal to the total scan width. This will avoid overexposure if there is an overlap, or missing data if the increment is greater than the scan width. The product of the number of data channels N and the width of each detector, or T, is the detector configuration. The detector configuration determines the beam width or beam collimation. A smaller total beam width will have a higher CTDI vol than a larger beam width. This is due to the scatter contributions of the adjacent beam widths in the current width. Scanning with a very low beam is considered inefficient for most applications. On a 16-slice scanner with a detector width per channel of 1.25 millimeters, a collimation of 4 by 1.25 millimeters is generally less dose efficient than a collimation of 16 by 1.25 millimeters. Always monitor the resulting CTDI vol when changing the detector configuration. The image on the left displays 3 different detector configurations, but all 3 result in the same beam width of 5 millimeters. The image on the right displays a larger beam width of 20 millimeters. The detector configurations on the left, keeping all other factors the same, will result in a higher CTDI vol and therefore higher patient dose due to the scatter contributions from the adjoining beam widths. The unit will need 4 scans using the beam width on the left to match 1 scan with the beam width on the right. Each of those scans will create scatter contributing to the dose to the patient. Pitch is only defined for helical scans. Pitch is the table speed per gantry rotation divided by the beam width, or detector configuration. Patient dose is inversely proportional to pitch. The faster you move the table through the gantry, the higher the pitch, the less exposure to the patient, therefore lower dose. Users should monitor other parameters when changing pitch. The scanner may or may not automatically compensate for changes in pitch. This slide shows some examples of pitch, from left to right. On the left is a pitch of less than 1. Beam width has some overlap from rotation to rotation. Assuming all other parameters are the same, the smaller pitch will equal the highest dose to the patient. In the center, pitch is equal to 1. No overlap of beam width. The table speed per rotation is equal to the beam width. The picture to the right has a pitch of greater than 1. Table speed per rotation is greater than the beam width, therefore resulting in the lowest dose to the patient. This does not mean areas of the subject are missed. Effective mass is the product of the tube current and the exposure time per rotation divided by the pitch. Since this is the mass value divided by the pitch, effective mass is a term that is used for helical scans only. The units are milliampere seconds, or mass. Patient dose is directly proportional to effective tube current time product, or effective mass. Not all CT units display effective mass. It is important to know the difference when operating the CT. Imaging in computed tomography is based upon the assumption of a single energy monochromatic beam. Bow tie filters are placed between the patient and the X-ray source to remove the lower energy X-rays, which contribute to dose and don't contribute to image formation. You can see from the diagram the bow tie filter is thicker in the locations where the beam will pass through less tissue towards the sides of the patient. Iterative reconstruction has replaced filtered back projection as the most prominent reconstruction process in CT. It is a feature that uses the information acquired during the scan as a model and repeats the reconstruction steps to produce an image with less noise. Less noise means better contrast to noise ratios and better CT images. Depending on the type of iterative reconstruction used, the image spatial resolution may also be improved. Iterative reconstruction starts with the model, which can be an initial filtered back projection image, and repeats the process to refine the image. The most important reason for implementing iterative reconstruction into your protocols is the resulting noise reduction can be utilized to save dose to the patient without a loss in image quality. This slide summarizes the acquisition parameters discussed and their effect on dose. Scan mode. Changes in the scan mode may affect patient dose. Table feed affects patient dose through its inclusion in pitch. Patient dose is proportional to 1 over pitch. Decreasing the beam width typically increases the patient dose. Patient dose is proportional to exposure time per rotation. Patient dose is proportional to tube current or MA. Patient dose is proportional to tube current time product, and patient dose is proportional to effective tube current time product or effective mass. Patient dose is also proportional to kVp1 divided by kVp2, all raised to the n power, where n is approximately 2. Changes in the beam shaping filter may affect patient dose, and the operator should be aware. Thank you for participating. Please be sure to print out your self-attested certificate. Questions can be directed towards Astarita Associates. Thank you.